You're sitting across from your child. Maybe they're in their wheelchair or propped up on the rug surrounded by their favorite toys.
Right.
The room is quiet. And in that quiet, you catch their eye.
Yeah.
And there's a spark there. You know, a glimmer of recognition, maybe a shared joke, just this deep, undeniable presence.
Absolutely.
You talk to them, and even though they don't answer back with words, you feel it in your gut. Like they are in there.
They're totally in there.
Right. They understand you. But then, you go to the neurologist or you sit in a school IEP meeting and you're handed this massive stack of charts.
For the paperwork?
Exactly.
Yeah.
The evaluations that tell a completely different story. You get these assessments that basically define your child entirely by what they can't do.
By the milestones they missed.
Yeah, by the words they can't speak. And it is just an incredibly isolating place to be, caught between the medical paperwork that sees profound delay and your own intuition that sees, well, profound potential.
It's a devastating disconnect, honestly. I mean, we rely so heavily in our society on measurable physical output to define human intelligence.
We really do.
We want a child to point or, to stack blocks or to speak a complete sentence.
Right.
And when a genetic condition strips away the physical ability to perform those specific tasks, the default assumption from the outside world is often that the cognitive ability must just be missing as well.
Which brings us to the core mission of this deep dive today. If you're listening to this, you are likely navigating the uniquely beautiful yet exceptionally challenging reality of raising a child with PURA syndrome.
Yeah.
We are bypassing the standard developmental rulebooks today because, honestly, they simply do not apply to your family.
Not at all.
We're diving into a concept that sits at the very heart of your child's journey, which is cognitive potential, presuming competence.
I love that phrase.
Me too. We're going to explore the central paradox of PURA syndrome, that massive discrepancy between what individuals with this condition can express physically and what they actually understand cognitively.
And to do this justice, we are pulling from a really comprehensive stack of medical literature and lived experiences today.
We've got a lot of sources.
We really do. We're looking at clinical reviews from orphan anesthesia and general reviews, right alongside comprehensive genomic analyses.
Yeah, heavy science.
Very heavy. We've combed through specialized medical literature from frontiers in pediatrics and neurology. But, medical data only gives us half the picture.
So true.
The other half, the really crucial half, comes from the resources and the real family stories gathered by the PURA Syndrome Foundation and rarechromo.org.
Okay, let's unpack this. Our goal today is to validate that spark you see in your child's eyes.
Yes.
We're going to explore the hard, biological, scientific evidence that proves why you should always set high expectations for your child.
Always.
We want to show you exactly how the cellular mechanics of PURA syndrome create a physical barrier, and why your child's silence never, ever equals a lack of comprehension. But to truly grasp how this cognitive potential gets trapped, we have to start at the cellular level, don't we? We need to look under the hood at the biology of the barrier.
We do. It requires tracing the condition back to its really microscopic origins. And what's fascinating here is how recently the medical community even realized it existed.
Oh my gosh, yes.
The genetic mutation was only officially discovered and named in 2014.
I mean, think about that timeline for a second. 2014, we have smartphones that are older than the medical diagnosis of this syndrome.
It's wild.
It is wild. If you're listening and you have a teenager with PURA, you spent the early years of their life completely in the dark.
Completely.
Your child was born, they were struggling with all these severe medical complexities in the NICU, and the doctors literally did not have a name for it. They were part of that undiagnosed community.
Yeah, and the advent of whole exome sequencing is what finally brought this into the light.
That new genetic testing.
Exactly. Before that technology became accessible, neurologists were looking at these children and seeing symptoms that mirrored other genetic conditions.
Like they look similar to other things.
Right. But the standard genetic panels kept coming back clear. Now that we can sequence the genome more comprehensively, we know what we're looking for.
But it's still so rare, right?
Exceedingly rare. Current data points to only around 706 to 780 confirmed cases worldwide. And that's distributed across about 60 countries.
So we are talking about a microscopic change in the DNA that affects less than 1,000 known people on the entire planet.
Just a tiny fraction of the population.
I was reading through the genomic analyses, and they pinpoint the exact location. It's a mutation or a deletion on chromosome 5q31.3.
Yep, specifically affecting the PURA gene.
Right. And the literature uses a very specific term for this, haploinsufficiency.
That's the one.
When I first read that, it sounded like dense medical jargon, but it actually describes the mechanism perfectly once you break it down.
Haploinsufficiency is, well, it's a beautiful, albeit really frustrating biological concept.
How so?
Well, you inherit two copies of most genes, right? One from your mother and one from your father.
Right.
For many genes, if one copy is broken or mutated, the other copy can just work a little harder and produce enough of the necessary protein to keep the body functioning normally.
Okay, so it's a built-in biological redundancy.
Exactly.
So if we think of the brain or the body like an airplane, having two copies is like having a co-pilot. If one pilot falls asleep or gets sick, the other one can still fly and land the plane safely.
That is a completely fair comparison. But haploinsufficiency means that for this specific gene, the PURA gene, having only one working copy is simply not enough.
The co-pilot can't fly it alone.
Right. 50% production of the protein it creates is insufficient to meet the demands of a developing human body. The single working copy just cannot pick up the slack.
Wow.
The threshold for normal development requires both copies to be firing at 100%.
And the structure of the PURA gene itself makes it even more vulnerable, doesn't it? The sources describe it as a single exon gene.
Yes.
Most genes are broken up into coding sections, which are the exons, and non-coding sections, which are the introns.
The standard gene is essentially like a rough draft. When the cell reads it, it cuts out the introns, which are the junk DNA or the non-coding filler.
Right.
And then it splices the exons together to make the final, clean set of instructions.
So if we picture the standard gene like a movie being filmed, the director shoots a bunch of scenes. Some of the scenes have mistakes or, boom mics in the shot.
Exactly.
But it doesn't matter because in the editing room, they just snip out the bad parts, the introns, and splice together the perfect takes, the exons, to make the final film.
That's a great way to look at it.
But a single exon gene like PURA doesn't have that luxury, does it?
It really doesn't. It is an unedited, continuous roll of camera film. There are 0 introns to cut out. The cell reads the sequence from start to finish in one continuous take.
No editing at all.
None. Because there's no editing process, every single piece of that sequence is absolutely critical.
Oh, I see.
If there's a smudge on the film, if a single frame is damaged or missing, like the highly common p233del mutation we see frequently in the clinical literature, the entire sequence is compromised. You cannot just splice around the error.
And what exactly is this unedited film trying to produce? I know it encodes a protein called Pur-alpha.
Yes, Pur-alpha.
And the literature emphasizes that this protein is highly conserved. When scientists use that phrase, they're talking about evolutionary perfection, aren't they?
They are. A highly conserved protein is one that is so fundamental, so incredibly vital to the basic mechanics of cellular life that evolution just hasn't allowed it to change over millions of years.
Wow. Millions of years.
Yeah. You find Pur-alpha not just in humans, but across a vast array of species. In the human body, it is completely ubiquitous. It's in the heart, the muscles, the blood.
But the main impact is the brain, right?
Yeah, exactly. Its most profound critical role is in the central nervous system. It basically acts as a master regulator for brain development.
And this is where we really start to see the physical barrier forming. If a child has haploinsufficiency of the PURA gene, they are only producing half the necessary amount of this highly conserved Pur-alpha protein.
Right.
So what is failing to happen in the brain as a result of that shortage?
We have to look at how neurons, the brain cells, how they communicate and grow. Pur-alpha binds to both DNA and RNA.
Okay.
It's essential for DNA replication, which is how cells divide and grow, but its most fascinating role is in mRNA transport.
mRNA, like the messenger RNA.
Exactly. Think of mRNA as the physical blueprint for building new cellular machinery. The nucleus of the brain cell creates this blueprint, but the blueprint needs to be delivered to the far reaches of the cell, way out to the dendrites.
The dendrites are the long branching arms of the brain cell that reach out to connect with other brain cells, right?
Yes, exactly.
And that connection point is the synapse.
And synapses are where learning happens. It is where memories are stored, where motor commands are formulated, where language is processed.
So it's the most important part.
Absolutely. To build and strengthen those synaptic connections, the dendrite needs materials. It needs local protein synthesis. And Pur-alpha is the transport vehicle.
Okay, I'm following.
It binds to the mRNA blueprints in the center of the cell and physically carries them down those long dendrite arms to the construction site at the synapse.
So if you only have half the amount of Pur-alpha, you only have half The transport vehicles.
Right.
The nucleus is making the blueprints, the cognitive desire to build the connection is absolutely there, but the trucks aren't available to take the instructions to the construction site.
That's exactly it. The construction of those vital neural networks slows to a crawl, but the transport of mRNA is just one part of the problem.
There's more.
Yeah. The other massive consequence of lacking Pur-alpha involves myelin.
Myelin. This is something that comes up in almost every single neurological discussion.
It's critical.
It is the protective, fatty sheath that wraps around our nerve fibers. I always picture it as the rubber insulation wrapped around a copper electrical wire.
That insulation is exactly what allows the electrical impulse, the signal from the brain, to travel at lightning speed down the nerve to the muscle.
Right.
Without thick, healthy myelin, that electrical signal leaks out. It degrades, it slows down dramatically, or it crossfires with other nerves. And the Pur-alpha protein is intricately involved in the process of creating that myelin sheath.
Which perfectly explains the consistent findings on MRI scans for these children. The radiologists are always noting delayed white matter maturation.
Yes, that's a key finding.
And white matter is essentially just the heavily myelinated areas of the brain, right?
Exactly. The brain is trying to insulate its wiring, but it just doesn't have the biological materials to do it efficiently.
So if we think about our computer analogy again, it's not that the hard drive is empty or the processor is broken. The issue is with the output cables.
Right, the connection is frayed.
The signal originates in the cognitive processor. The child forms the thought.
Yes.
But when the brain tries to execute the command, when it tries to send the signal down the uninsulated, undermyelinated wire to the arms, the legs, or the mouth, the signal encounters massive physical resistance.
And that biological bottleneck doesn't just show up later in life when they, miss a walking milestone. No,
Yeah.
this deficit manifests physically from the very moment of birth. In fact, reading the clinical presentation and the sources, it paints a picture of extreme, terrifying medical fragility in the NICU.
The hallmark physical manifestation from day one is severe central hypotonia, isn't it? In the older medical texts, they often call it the Floppy Baby Phenotype.
They do. And hypotonia is a term that gets thrown around a lot, but we really need to differentiate it from just being weak.
Yeah, that's an important distinction. Weakness implies that the muscle fibers themselves are degraded or damaged, like in muscular dystrophy. But hypotonia means low muscle tone. A healthy muscle, even when you're completely relaxed and fast asleep, maintains a baseline level of tension.
It's a neurological readiness.
Exactly. That resting tension is what allows you to hold your head up, to keep your joints aligned, to fight against the constant pull of gravity.
But in PURA syndrome, that baseline tension just isn't there. And the key diagnostic clue is that it is central hypotonia.
Central, meaning from the brain.
The origin of the low tone is central, meaning the brain and the spinal cord, not peripheral. We know the muscles and the peripheral nerves are structurally capable because the deep tendon reflexes are usually preserved.
Oh, that makes sense.
Yeah, if a neurologist taps the baby's knee with a reflex hammer, the leg will kick. The local hardware works perfectly.
But the signal is dropping.
Right. The continuous subconscious signal from the brain instructing the body to maintain its resting tone is failing to get through those undermyelinated pathways.
And this lack of tone, it affects every single system in the infant's body. The medical literature highlights neonatal feeding difficulties as a primary crisis. They use the term dysphagia.
Yes, an inability to swallow safely.
Which is wild because swallowing is something we never ever think about.
Never.
But it's an incredibly complex, high-stakes motor task. It requires the precise, rapid-fire synchronization of over 50 different pairs of muscles in the mouth, pharynx, and esophagus.
And you have to coordinate sucking, swallowing, and breathing in a perfect rhythm.
Right. Otherwise, you aspirate fluid into the lungs.
Exactly. If the signals to those 50 muscles are delayed or weak because of the central hypotonia, that perfect rhythm is just impossible.
It's no wonder that over 80% of neonates with PURA require immediate feeding support.
It's a huge number.
Families are dealing with nasogastric tubes, the NG tubes, taped to their fragile newborn's face. And very often they have to progress to surgically place G tubes directly into the stomach.
Yeah, just to ensure the child can grow without aspirating milk and getting pneumonia.
And the respiratory distress is equally severe. Over 50% of these infants experience recurrent sleep apnea. And we see both types, central apnea and obstructive apnea.
And central apnea is terrifying.
It really is.
It literally means the brainstem, the most primal part of the brain, just forgets to send the electrical impulse to the diaphragm to take a breath.
The biological metronome just pauses.
Yes. And then you layer on obstructive sleep apnea, which is driven by the hypotonia.
Because everything is so floppy.
Right. The muscles of the upper airway and the throat are so floppy that when the baby falls asleep and the muscles relax even further, the airway physically collapses inward, blocking the oxygen.
So the infant's brain is constantly being jerked out of deep restorative sleep to essentially jolt the body awake so it doesn't suffocate.
The exhaustion that places on a developing brain is unimaginable.
And there's also hypothermia, which the sources mention as an inability to regulate body temperature.
Which again points to the brainstem and the autonomic nervous system.
The things you don't think about.
Right. The autonomic system controls everything you don't have to consciously think about. Heart rate, digestion, temperature. The Pur-alpha deficiency is heavily impacting the fundamental regulatory wiring of the body.
You know, there's one clinical observation in the literature that struck me profoundly. It's something so many mothers in the PURA community talk about experiencing before the baby was even born.
Oh, the hiccups.
Yes, excessive wild hiccups in the room.
It's fascinating. It began as an anecdotal story shared among families, and now it is an officially recognized clinical feature.
Wait, really? Just from parents talking?
Yeah, that's how a lot of this gets discovered. A hiccup is a reflex spasm of the diaphragm muscle. In a neurotypical fetus, the brain eventually matures enough to exert inhibitory control over those spasms.
But in PURA?
In PURA syndrome, that disorganized, undermyelinated neural circuitry struggles to send the inhibitory signal. The diaphragm just keeps spasming.
When you look at this entire clinical picture, the feeding tubes, the oxygen monitors for apnea, the inability to regulate temperature, the profound floppiness where the infant can't even lift their own head against gravity.
It's overwhelming.
It creates an incredibly thick physical mask. It is entirely understandable why a doctor evaluating this infant, or even the outside world observing them, would look at that massive physical impairment and assume the cognitive development must be equally devastated.
Historically, that was the tragic assumption of the medical field. Severe physical impairment was inextricably linked to severe intellectual disability in the eyes of traditional diagnostics.
Because they couldn't see past the body.
Right. If a child cannot physically interact with their environment, if they can't reach for a brightly colored toy, if they can't mimic a smile or babble or manipulate a puzzle, they will score at the absolute bottom of any standard developmental assessment.
Which leads us out of the biology of the barrier and into the absolute core of our discussion today. That physical mask hides a profound truth. We have to look at the receptive-expressive discrepancy.
Yes, this is the moment where the narrative of PURA syndrome shifts entirely.
It really does.
It moves from a list of devastating physical deficits to an astonishing story of hidden cognitive strength. The medical literature, including the genomic reviews, now explicitly lists this discrepancy as a hallmark of the syndrome.
Let's clearly define what this discrepancy means for the listener. We are talking about the massive gulf between expressive language and receptive language.
Okay, let's break that down.
Expressive language is the output. It's the ability to speak a word, to write a sentence, or to physically coordinate your hands to use sign language. Receptive language is the input.
The understanding.
Right. It's the ability to process the words you hear, to comprehend the abstract concepts of the world around you, and to understand information.
And in the vast majority of individuals with PURA syndrome, that expressive language, the output, is severely impaired. Most individuals remain non-speaking or nonverbal throughout their entire lives.
And even if they do speak.
Right. The subset of individuals who do eventually develop verbal speech typically only use single words or very short, simple phrases.
And we know exactly why, based on the biology we just discussed. The physical act of articulating a word is an athletic feat for the mouth.
It really is an athletic feat.
It requires the lungs to push air, the vocal cords to vibrate at a precise frequency, and the tongue, lips, and jaw to shape that air into a specific consonant or vowel.
It's incredibly complex.
When a child has severe oromotor hypotonia and dysarthria, which is the weakness in the speech muscles, that athletic feat is nearly impossible. The uninsulated wiring just can't deliver the complex sequence of commands fast enough.
But the clinical studies, the data from the Rare Crummel Foundation, and the countless reports from the PURA Syndrome Foundation all consistently highlight the other side of the coin.
The receptive side.
Yes. These same patients demonstrate a remarkably high level of receptive understanding. They can follow simple instructions, and very often they can follow incredibly complex, multi-step commands.
The reason for this gap lies in the geography of the brain itself, doesn't it? Comprehension and motor execution happen in totally different places.
Precisely. The cognitive processing centers for language, areas like Wernicke's area in the temporal lobe, which handles the comprehension of spoken words, are actively engaged.
So the hard drive is storing the vocabulary.
Yes, the processing chip is decoding the grammar and the tone of voice. But when Wernicke's area tries to send the message to Broca's area and the motor cortex to actually speak the response, the signal hits that undermyelinated roadblock.
So presuming competence is not just some feel-good, overly optimistic parenting mantra.
Not at all.
It's a scientifically validated, medically supported approach to raising a child with PURA syndrome. The science tells us the comprehension is there.
Absolutely.
But, reading the clinical data is one thing. Hearing it from the families living it is something else entirely. I want to bring in the voices from the resources provided by the PURA Syndrome Foundation.
Oh, please do. The family stories are so powerful.
They quote the family of a 14-year-old boy named Aiden. His parents wrote, "I have learned from Aiden that being nonverbal is not the same thing as not being able to communicate, and being non-ambulatory does not prevent him from being independently mobile. We've learned new ways of being in the world with Aiden so that he can live life more fully."
It is a profound realization. Aiden's family had to completely decouple the concept of communication from the physical act of talking.
They really did. And then there's the family of 7-year-old Sarah, they noted. Sarah has great receptive language skills, but has been unable to say more than the occasional word. This is the universal thread that binds this community together.
Yeah, the parents know the kids are tracking everything that is going on.
They are absorbing their environment constantly. They recognize the difference between the voices of their siblings and strangers.
Oh, definitely.
They understand emotional tone. Like if you are stressed, they
Right.
know it. They comprehend daily routines, and they are building an internal dictionary of the language being spoken around them, even if their mouth refuses to echo a single word of it back.
I can imagine a listener nodding along to this, just feeling incredibly validated. But I also know the intense skepticism families face.
Oh, the pushback is real.
You get it from extended family members who don't understand, from educators who rely on standardized testing, and sometimes from doctors who haven't read the latest literature on PURA.
Right. The pushback is always, well, if the child cannot speak and their motor skills are so heavily impacted by the hypotonia that they can't even point to a picture reliably, how do you actually know they're understanding you?
Exactly.
How are you scientifically measuring this hidden intelligence when the output cables are completely frayed?
It is the crucial question, and it highlights exactly why traditional IQ tests are worse than useless for this population.
They're actually harmful.
They are actively harmful because they yield false negatives. To measure intelligence when motor output is severely compromised, neurologists and specialized speech therapists have to look for micro-expressions of comprehension.
We have to bypass the skeletal muscles entirely and look at the physiological responses.
Eye tracking is one of the most reliable early indicators. The ocular muscles, the ones controlling the movement of the eyes, are often spared the worst of the severe hypotonia that affects the limbs.
Oh, really? That's interesting.
Yeah. We watch the child's gaze.
Mm-hmm.
If you place 3 objects in front of them and say, look at the red cup, does their gaze shift consistently to the red cup?
And if it does?
If it does, they have demonstrated auditory processing, vocabulary comprehension, and color recognition, all without moving a single finger.
That's incredible. You also look for behavioral responses to specific sounds or names, right? Like, do they show anticipatory excitement?
Anticipation is a massive indicator of high-level cognitive processing.
Because they have to think ahead.
Exactly. If you tell a child, we're going to the park after lunch, and an hour later as you finish eating, they start vocalizing excitedly or their breathing rate changes in anticipation, that is profound proof of receptive language.
They remember.
They didn't just understand the words. They processed the abstract concept of a future event, retained it in their working memory, and reacted to it.
Now, here's where it gets really interesting. The ultimate undeniable proof always comes later, when the child is finally provided with the right alternative communication tools.
Yes, when they get the right tech.
When a nonverbal child who has been trapped in their own body for years is finally given a machine they can control with their eyes, and within weeks they are using it to request specific items, or to tell a joke, or to express frustration,
It changes everything.
it proves unequivocally that the cognitive foundation was being built that entire time. The vocabulary was filed away in the hard drive. They just needed a functional output cable to print it out.
Which brings us to the most vital intervention we can offer, If we know the thoughts are in there, if the receptive language is robust, how do we build the bridge?
We break the silence with augmentative and alternative communication, or AAC. The clinical guidelines are incredibly explicit about
They
this.
really are.
Early intervention with speech and language therapy is paramount. But, and this is a massive but, traditional speech therapy alone is not going to cut it.
Traditional speech therapy heavily focuses on vocalization. It involves lip trills, tongue placement exercises, blowing bubbles to build breath support.
Which is fine, but
While those exercises are important for maintaining oral motor function and safe swallowing, relying on them as the sole method for communication is a huge disservice to a child with PURA.
because you are fighting a losing battle against the neurological hardware, you can practice tongue placement for the letter L all day long, but if the myelin sheath isn't thick enough to conduct the signal from the brain to the tongue at the exact millisecond required, oral speech is going to remain agonizingly difficult.
Exactly. This is why the early aggressive implementation of AAC is a foundational recommendation.
And AAC is a broad umbrella term, right?
Yes, very broad.
It encompasses any tool, system, or strategy used to help a person communicate when traditional speech is not possible or not clear enough to be understood by strangers.
And because the physical presentation of PUA syndrome can vary in severity, we categorize these tools based on the child's specific motor abilities.
Let's break down those categories, starting with children who might have some level of gross motor control, but struggle with fine motor dexterity.
For those individuals, we look at low-tech AAC options. Manual signing is an option, but standard American Sign Language requires immense fine motor control.
Right, individual finger isolation, spatial memory.
That is usually too physically demanding. So therapists will often modify it to keyword sign. This focuses on very simple, broad gestures that rely on gross motor movements to convey core concepts like more, finished, or eat.
But signing still requires a physical output that might exhaust a hypotonic child. That is where symbol-based communication boards come in.
Yes.
The literature frequently mentions systems like PODD, pragmatic organization, dynamic display. PODD is brilliant because it reduces the motor burden on the child.
It is essentially a large, heavily organized binder filled with pages of categorized symbols and pictures. If a child can point, they point.
And if they can't,
But if pointing is too difficult or their arm gets tired, POD relies on partner-assisted scanning.
the communication partner, like the parent or the therapist, does the physical labor. The partner points to the symbols one by one or turns the pages asking, is it on this page? Is it this row?
Right.
And the child uses a micro-expression, a subtle nod, an intentional blink, or a specific vocalization to indicate yes when the partner lands on the right word.
The child is entirely in the driver's seat cognitively, but the partner acts as the physical engine.
That's such a great way to put it. And for individuals with the most severe motor limitations, those who cannot reliably use their hands or head at all, we look to high-tech eye gaze technology.
This technology is nothing short of transformative.
It looks like something out of a sci-fi movie. It's a tablet computer equipped with specialized infrared cameras mounted at the bottom. The cameras bounce infrared light off the child's pupils to track exactly where they are looking on the screen.
The child simply looks at a symbol or a word on the screen and holds their gaze there for a fraction of a second, which is a process called a dwell time.
Okay.
The machine registers that sustained gaze as a selection and speaks the word out loud using a synthesized voice. It entirely bypasses the need for the skeletal muscles of the arms, neck, or mouth.
It taps directly into the brain's control of those ocular muscles.
Yes, exactly.
Providing these tools is about so much more than just logistics, though. It isn't just about giving the child a way to ask for a glass of water or a different toy.
No, it's way deeper than that.
It touches on something deeply psychological, which is highlighted across all the family stories. Individuals with PURA syndrome are consistently described as highly social, friendly, and deeply affectionate.
They have a profound, innate drive to interact with the people around them. Imagine having that intense desire for social connection, but being physically trapped in silence.
It would be incredibly isolating.
AAC gives them a mechanism to project their personality into the room. It allows them to tell a joke, to tease a sibling, to say, I love you.
But as parents implement these systems, they have to reframe their expectations of what progress looks like. Progress with AAC, especially in the context of PURA syndrome, is highly nonlinear.
It is not a steady upward trajectory where they learn 5 new words every week like a neurotypical toddler.
Not at all.
Progress might look stagnant for months and then suddenly shift. Progress might look like a child making a brand new intentional vocal sound that they've never made before while looking at a symbol.
Or progress might be entirely internal for a long time. They might not use the eye gaze machine to speak a single word for the first year, but they're watching you use it.
They are absorbing it.
They are demonstrating their comprehension. If you say, go get your red shoes, and they slowly army crawl down the hallway and touch the red shoes, that is massive progress.
Huge progress.
The internal neural wiring is being laid down, even if the expressive output is still heavily delayed.
There's a significant anxiety that parents face when introducing AAC, especially early in a child's life.
Oh, the lazy myth.
Exactly.
Yeah.
The fear is that providing a screen or a picture board will act as a crutch. Parents worry that if they give the child an easy way out, the child would become lazy and simply give up on trying to use their actual natural voice.
I hear that pushback all the time, but it's a fundamental misunderstanding of how the brain works. The medical and therapeutic consensus firmly, categorically debunks the myth of the lazy AAC user.
Giving a child AAC does the exact opposite.
Think about the psychological weight of frustration. Imagine knowing exactly what you want to say, knowing the answer to the question, but your mouth refuses to form the words.
It would be maddening.
The stress and anxiety of that failure actually shut down the language centers of the brain. When you provide an AAC device, you immediately relieve that stress. The child realizes, I have a voice. I can be understood.
And from a neurological standpoint, using the AAC device actively builds and strengthens the language pathways. They are practicing syntax, they are navigating categories.
They're engaging in conversation.
Yes, they are engaging in the rapid back and forth rhythm of human conversation. The cognitive machinery is getting a full workout.
And it actually helps speech, right?
Studies consistently show that rather than suppressing natural speech, AAC use often increases natural vocalizations.
Because they're relaxed.
Exactly. When the immense pressure to articulate perfectly is removed, the child relaxes. The device models the spoken word perfectly. The child hears it, and in that relaxed state, they often attempt to mimic the sound alongside the device.
The AAC is a bridge to speech, not a replacement for it.
Precisely.
So we have this bridge built. We are presuming competence. We're putting PODD books or eye gaze devices in front of them, and we're ready to hear what they have to say.
Right.
But we have to confront the brutal reality of the physical toll this syndrome takes on the human body. Because no matter how brilliant the child is, and no matter how advanced the AAC technology is, their cognitive potential can be heavily, sometimes entirely, clouded by massive physical hurdles.
You cannot view cognitive development in a vacuum. The mind is housed in a body. And in PURA syndrome, that body is frequently under significant multisystemic siege.
If we want the cognitive potential to shine, we have to look at the physical fires that need to be put out.
The most prominent and often the most terrifying of these hurdles is epilepsy.
The clinical data is stark. Over 50% of individuals with PURA develop epilepsy. It typically onsets between the ages of 2 and 5 years old.
And we are not talking about a mild, easily controlled form of epilepsy where a child takes a single daily pill and never has another seizure.
No.
The epilepsy associated with PURA is often complex. It is frequently refractory, meaning it resists standard anti-seizure medications, and it evolves over time.
Why does lacking the Pur-alpha protein cause the brain to short-circuit like this?
It comes right back to the myelin sheath. Myelin doesn't just speed up signals, it acts as an insulator to prevent crosstalk between neurons.
It's insulation again.
Right. When you have a brain that is undermyelinated, the electrical signals leak. A signal meant to travel down one specific pathway jumps the track and excites neighboring neurons.
Oh, wow.
That localized short-circuit cascades, creating a massive, uncontrolled electrical storm in the brain. That storm is a seizure.
The literature outlines a terrifying spectrum of these storms. It often begins with myoclonic jerks. Mechanistically, what is happening during a myoclonic jerk?
A myoclonic seizure is a sudden, extremely brief, involuntary muscle contraction. It is an aberrant electrical spark in the motor cortex that sends an instantaneous, forceful command to a muscle group.
So it's not a full-body convulsion yet.
Not necessarily. It can be subtle, looking like an exaggerated startle reflex, or it can be violent enough to cause a child to violently throw their arms out, drop whatever they are holding, or suddenly collapse to the floor. They often happen in rapid clusters.
And from there, the uninsulated brain is vulnerable to generalized tonic-clonic seizures. These are the seizures most people are familiar with from television. A complete loss of consciousness, the body stiffens in the tonic phase, and then violently convulses in the clonic phase as the electrical storm engulfs the entire brain. But the most devastating progression mentioned in the literature is the evolution into Lennox-Gastaut syndrome.
Lennox-Gastaut Syndrome, or LGS, is a severe epileptic encephalopathy. This is a catastrophic diagnosis.
Why is it so severe?
It means the child is experiencing multiple different types of seizures every single day. Their EEG, the brainwave monitor, shows a constant chaotic pattern of abnormal background activity. And tragically, LGS is almost always accompanied by cognitive stagnation or even regression.
This highlights exactly why the aggressive, relentless management of epilepsy is the #1 priority for preserving cognitive potential. Think about it. If a child is having constant subclinical seizures,
Electrical storms that might just look like a brief blank stare or a flutter of the eyelids.
right, if that's happening, their brain is entirely occupied with simply surviving the chaotic misfires.
You cannot focus your eyes on a communication board. You cannot process a complex instruction. And you certainly cannot learn a new skill if your brain is experiencing constant neurological static.
The intelligence is there, but the static drowns it out.
Managing this requires a highly specialized epileptologist. Because the PURA mutation affects every cell in the brain, surgical removal of a focal point, like cutting out the bad piece of brain tissue, just isn't an option.
Because the whole brain is affected.
Exactly. So families are thrust into a relentless trial and error process with complex multi-drug regimens.
They're trying to find the precise pharmacological cocktail that calms the electrical storms without overly sedating the child.
Which is incredibly hard.
Because if you heavily sedate them to stop the seizures, you also sedate their cognitive awareness. It is a razor-thin tightrope. Families also frequently turn to non-pharmacological interventions like vagus nerve stimulation or VNS.
The VNS is essentially a pacemaker for the brain, right?
Yeah, a device is implanted in the chest, and it sends regular, mild electrical pulses up the vagus nerve in the neck into the brainstem, helping to disrupt the abnormal seizure patterns before they can spread.
Exactly. And specialized medical diets, specifically the ketogenic diet, are often employed too.
Like the high-fat diet.
Yes. By shifting the brain's primary fuel source from glucose to ketones derived from fat, the metabolic environment of the brain changes in a way that often raises the seizure threshold, offering variable but sometimes significant relief for drug-resistant epilepsy.
The battle against epilepsy is exhausting, but it's not the only neurological hurdle. The sources also detail a high prevalence of non-epileptic movement disorders, specifically dystonia and dyskinesia.
These are involuntary sustained muscle contractions. The basal ganglia, the part of the brain that smooths out and coordinates movements, isn't getting the right signals.
So the muscles fight each other.
Exactly. This causes the muscles to constantly fire against each other, creating repetitive twisting movements or locking the child into abnormal, painful postures.
Again, picture the cognitive toll. Imagine trying to use your precise ocular muscles to select a word on an eye gaze screen, while your arm is involuntarily and forcefully pulling your body in the opposite direction due to dystonia.
It takes an immense amount of cognitive energy just to fight your own body for physical control.
And we also see a very specific, fascinating neurological quirk in PURA syndrome, hyperacusis, which manifests as a pathological, exaggerated startle response.
Well, a pathological startle.
What does that mean in practical terms?
It means the brain's filtering system is broken. In a neurotypical brain, if a door slams unexpectedly, you startle, your heart rate jumps, but then inhibitory neurons immediately fire to tell your brain, it's just a door, you're safe, and you calm down.
But in PURA,
The lack of Pur-alpha seems to impair those inhibitory neurons.
so a sudden noise, a dog barking, or even just the sudden unexpected touch on the arm triggers a massive, prolonged neurological overreaction. Their nervous system treats a dropped spoon like a bomb going off.
It is such a distinct, common feature of the syndrome that neurologists are now trained to look for this exaggerated startle in hypotonic infants as a key clinical indicator to order targeted genetic testing for the PURA gene.
Now, we've spent a lot of time on the brain, but Pur-alpha is present throughout the body, so we have to step outside the neurological system. The extra neurological issues create a massive physical burden. The literature states that 48% of these children develop scoliosis.
Scoliosis is an abnormal progressive curvature of the spine. While some children are born with spinal anomalies in PURA syndrome, the scoliosis is largely neuromuscular.
Oh, so it's tied back to the tone.
Exactly.
Hmm.
It's driven by that chronic central hypotonia we discussed earlier, The muscles of the trunk, the core, and the back simply lack the resting tension required to act as guy wires supporting the spinal column as the child grows heavier and taller.
Gravity literally wins the battle. The spine begins to curve and twist. And this isn't just a cosmetic issue.
Not at all.
As the curve progresses, it compresses the internal organs. It crushes the lungs, further exacerbating the respiratory and apnea issues.
It frequently reaches a point where major orthopedic intervention is required. Spinal fusion surgery, where rods and screws are bolted into the spine to forcefully straighten and stabilize it, becomes a medical necessity.
Just to save the child's respiratory function and allow them to sit upright comfortably in their wheelchair.
Right. Add to that the prevalence of hip dysplasia. The hip joint is a ball and socket. It forms correctly during childhood because the child is standing, walking, and putting dynamic, weight-bearing stress on the joint.
Which forces the socket to form deeply around the ball.
Exactly. But if a child is non-ambulatory and profoundly hypotonic, that dynamic pressure never happens. The socket stays shallow, and the hip can easily dislocate, causing immense chronic pain.
This lack of weight bearing also leads to osteopenia, or low bone density. Bones are living tissue. They rely on a principle called Wolff's Law.
Wolff's Law, yes.
It dictates that bone will adapt to the loads under which it is placed. If muscles are pulling hard on the bone and gravity is stressing the bone through walking, the bone calcifies and hardens. Without that mechanical stress, the bones remain fragile and are highly prone to fractures from minimal trauma.
We also cannot ignore the gastrointestinal system. Chronic, severe constipation is an almost universal complaint in the PURA community.
People often forget that the gut is entirely lined with smooth muscle. The intestines have to contract in a coordinated wave, peristalsis, to move food and waste through the digestive tract.
In PURA, the hypotonia affects the smooth muscle as well. The gut is sluggish, the waste simply doesn't move, leading to impactions, severe bloating, and agonizing abdominal pain.
Let's pull all of this together. If you, as a healthy adult, were experiencing severe constipation, recovering from a dislocated hip, fighting off a seizure, and exhausted from sleep apnea, you wouldn't be chatting amiably or solving complex puzzles.
You'd be miserable.
You'd be completely checked out, retreating inward just to manage the physical agony.
Which is exactly why the medical management of these conditions is intrinsically linked to unlocking cognitive potential. You have to clear the physical path.
Right.
You have to prescribe the bowel regimens to clear the gut. You have to stabilize the spine with surgery. You have to calm the electrical storms with anti-seizure medications. When you relieve the physical suffering, the child's mind suddenly has the energy and the bandwidth to engage with the world.
And this underscores the critical importance of getting the correct genetic diagnosis early. We talked about how new PURA syndrome is, only discovered in 2014. The literature describes the agonizing diagnostic odyssey that families endure.
It's an odyssey for sure.
Before the genetic test confirms PURA, these children are subjected to endless batteries of tests and are frequently misdiagnosed.
They're often misdiagnosed with Prader-Willi syndrome in the NICU because of the profound neonatal hypotonia and the failure to feed. Or, as they get slightly older and the seizures start, they might be misdiagnosed with Rett syndrome or Angelman syndrome.
Because of the loss of purposeful hand movements and the severe communication deficits.
Exactly. But getting the exact sequence, knowing that it is haploinsufficiency of the PURA gene, changes the entire game. It stops the guessing.
It tells the medical team exactly what to anticipate. They know to proactively monitor the spine for scoliosis. They know to watch for the specific onset of myoclonic seizures. The right diagnosis clears the physical path so the cognitive self can eventually emerge.
It allows the family and the entire care team to stop living in a state of constant, terrifying reaction to unexpected medical crises and transition into a state of proactive management, focusing on long-term developmental growth.
Which is exactly where we're going next. Because despite these massive, overwhelming physical hurdles, these children survive. They adapt. They grow into teenagers and eventually adults.
Yes, they do.
We need to look at the long-term trajectory. What does adulthood, behavior, and continuous growth look like when you're living with PURA syndrome?
There is a vital, immensely encouraging fact buried in the medical literature that every parent needs to hold on to. PURA syndrome is a neurodevelopmental disorder. It is not a neurodegenerative disorder.
We really need to underline that heavily. It is a massive distinction.
It's huge. A degenerative disorder is one where a child might acquire skills, they might learn to walk or say a few words, but then the disease actively attacks the nervous system, and they progressively lose those skills.
They regress.
They regress until the bodily functions fail. PURA syndrome does not do that. while the developmental progress is excruciatingly slow and the physical milestones are severely delayed, the skills they do acquire are generally retained.
Assuming their epilepsy is well managed and not causing secondary brain damage, they don't go backwards. If we
Oh.
go back to our earlier analogy, the staircase they are climbing is incredibly long, and the steps are very far apart, but they are always climbing.
Precisely. The slow, steady accumulation of skills and comprehension continues throughout their entire life. They are lifelong learners.
But as they grow physically larger and as they enter the teenage years and adulthood, the hormonal shifts and the growing awareness of their own limitations bring significant emotional and behavioral challenges.
The sources repeatedly note that while individuals with PURA are typically loving and social, they can develop complex behavioral profiles.
As they age, we see reports of increased anxiety. This is often triggered by sensory overload, which ties back to that hyperacusis and poor filtering, or by sudden changes in their routine.
We see sensory seeking or avoidance behaviors, which might look like intense hand flapping, repetitive rocking, or extreme aversions to certain textures. And most distressingly for caregivers, we can see instances of self-injury, like hand biting, or aggression towards others.
Now let's tie this right back to the core theme of presuming competence. Why are these behaviors happening? If we presume they understand their environment, we have to look at these behaviors through a completely different lens.
We have to embrace the psychological truth that behavior is communication. It is the rawest, most primal form of output.
Put yourself in their shoes. Imagine you're 16 years old. You have the cognitive comprehension of a teenager. You understand that your daily schedule has been abruptly changed. You understand that the room you are in is far too loud and it's hurting your ears. You understand that your hip is aching. Or maybe you just understand that you absolutely do not want to watch the cartoon your well-meaning caregiver just put on the television.
But your body is a locked box. Your hypotonia prevents you from pointing to the door to leave. Your dysarthria prevents you from verbalizing the word no or stop. You are denied any recognizable, socially acceptable, expressive outlet.
The frustration would be astronomical. The emotional pressure builds up inside that locked box until it inevitably explodes behaviorally.
Exactly.
A teenager might bite their own hand until it bleeds or lash out and strike a caregiver, not because they are an inherently aggressive or malicious person, but because an explosive physical action is the only mechanism they have left to exert control.
It's the only way they can forcefully communicate, I am overwhelmed, I am in pain, or I demand a change.
This is the immense danger of not presuming competence. If a doctor or an educator assumes the child doesn't understand the world around them, they will look at that self-injury or aggression and simply view it as a random, meaningless symptom of severe intellectual disability.
And their solution will just be to medicate the behavior away with sedatives.
But if you presume competence, you look at that behavior and you ask the critical question, what are they trying to tell me? What is the trigger?
Which brings us full circle to AAC. Introducing robust, reliable, augmentative, and alternative communication from day one is not just about teaching them to say hello or I want juice.
It's preventative.
It is foundational preventative mental health care. By giving them a reliable tool to exert autonomy, to make choices, and to express dissent, you're providing a pressure release valve. You're actively preventing future behavioral crises by giving them a voice before the frustration turns into self-harm.
So what does this all mean? We arrive at the most difficult question, the question that I know keeps parents up at night as they try to navigate this journey. How do we balance this?
Balance is key.
How do you set these high expectations, presuming competence, fighting the insurance companies for eye gaze devices, believing deeply that they understand everything, while simultaneously facing the crushing daily reality of a severe, life-limiting physical disability?
It's tough.
How do families walk that line without setting themselves and their children up for a lifetime of constant heartbreak and disappointment?
It is the ultimate tightrope walk of raising a medically complex child. The secret to finding balance is to fundamentally redefine what the phrase high expectations actually means in the context of PURA syndrome.
Let's explore that definition. What do high expectations look like on a Tuesday morning in a house with a child with PURA?
High expectations mean you operate under the absolute assumption that your child understands every word you say. It means you speak to them using age-appropriate language, not baby talk.
Right. If they're 14, you talk to them like a 14-year-old.
Exactly. You read them complex books. You explain the nuances of what is happening around them. You assume they want to be actively involved in the family dynamic. And crucially, You demand that doctors and teachers never ever talk about them as if they aren't in the room.
Because the science proves they are in the room, they are listening, they're processing.
Yes, you hold the highest possible expectations for their cognitive presence. But you must balance that by holding deeply realistic, scientifically informed, and forgiving expectations for their physical output.
Realistic expectations mean looking clearly at the clinical data we discussed. It means accepting that because of the lack of Pur-alpha and myelin, it might take them 10 times longer or 100 times longer to physically move their hand to touch a switch or cast their gaze to a screen.
It means acknowledging the biological timeline. Independent walking, if it is achieved at all, usually happens between the ages of 3 and 10 years old, and the gait will likely always be unsteady. It means accepting the reality that speaking fluid, verbal sentences may never happen in the traditional way.
You stop measuring your child's success against the neurotypical milestones printed on the pediatrician's wall chart. You throw that chart away.
Throw it right out.
You start measuring success against their own unique baseline. You celebrate the micro milestones, the intentional blink, the new vocalization, the successful use of an eye-gaze dwell.
It requires separating the mind from the physical limitations of the body. You advocate fiercely and relentlessly for the brilliance of their mind, while providing endless grace, patience, and medical support for the struggles of their body.
And when families manage to find that delicate balance, that is when the environment is optimized for the child to truly thrive, communicating in their own unique way, surrounded by a world that finally believes in their potential.
I couldn't agree more.
We have covered an immense amount of ground in this deep dive. Let's recap the journey of the medical data and the family experiences we've explored today.
We started at the microscopic level, looking at the hard biology of PURA syndrome. We learned that the haploinsufficiency of the PURA gene, that unedited single exon strip of DNA, means the body only produces half the necessary Pur-alpha protein.
That shortage creates a profound physical barrier. It halts the transport of mRNA to the synapses, and it disrupts the creation of myelin, leaving the brain's wiring uninsulated.
That lack of insulation results in severe central hypotonia. The brain's hardware is struggling to send the signals, leaving the infant Floppy unable to safely swallow and battling severe sleep apnea.
But inside that struggling body, the cognitive machinery is quietly working. The receptive-expressive gap is the defining feature of PURA syndrome. The Wernicke's area is processing the language even when the motor cortex cannot execute the speech. They understand so much more than they can say.
We discussed how we bridge that agonizing gap by presuming competence and implementing augmentative and alternative communication early and consistently. Whether that is a partner-assisted PODD book or a high-tech infrared eye gaze device, AOC provides the necessary output cable for their stored vocabulary.
And we recognize the harsh truth that to let that cognitive potential shine, we have to aggressively manage the physical fires. We must tackle the severe drug-resistant epilepsy that causes neurological static.
We have to intervene with spinal fusions for scoliosis and manage the gastrointestinal hypotonia because a child who is in chronic pain or in the middle of an electrical brainstorm cannot focus on communicating.
But if the medical team and the family can clear that physical path and provide that vital communication bridge, these children will continue their slow, beautiful, non-degenerative developmental progress throughout their entire lives.
We know that reading the raw medical literature about your own child's genetic condition can feel like a gut punch. It can be terrifying to look at the clinical statistics on Lennox-Gastaut Syndrome or severe orthopedic surgeries.
But the ultimate takeaway from this deep dive, pulling from all these rigorous scientific sources and the lived experiences of the community, is deeply, profoundly empowering.
Your intuition as a parent, that feeling in your gut when your child looks at you and you just know they understand the joke or they understand the plan for the day, is not wishful thinking.
It is not a coping mechanism. It is medically validated. The hard science, the brain anatomy, and the genetic data all back you up. They are in there.
They absolutely are. And your unwavering belief in their hidden potential is the key that unlocks their world.
I want to leave you, the listener, with one final provocative thought to ponder as we wrap up our deep dive today. Our society defines intelligence almost entirely by output and by speed.
Speed is everything to us.
We measure how quickly someone can speak a thought, how clearly they can write an essay, how fast they can solve a puzzle with their hands. Our entire educational and societal structure is built around rewarding fast physical articulation.
But if a child with PURA syndrome processes complex emotions, anticipates future events, follows your instructions, navigates a high-tech communication device using only the microscopic movements of their eyes, and connects with you on a profound, soulful level without ever saying a single spoken word, what does that teach us about the true nature of human intelligence?
Perhaps the definition we use is far too narrow. Perhaps the burden isn't on them to learn to speak our fast, loud, physically demanding language. Perhaps the burden is on us to slow down, to watch the micro-expressions, to provide the tools, and to learn how to truly listen to theirs.
That's beautifully said.
Thank you so much for joining us on this deep dive into the science and soul of PURA syndrome. We encourage you to connect with the PURA Syndrome Foundation and the Rare Chromo Network to find other families walking the same path. We wish you and your incredibly resilient children immense strength and joy on your journey.